So welcome to today's webinar. This is a webinar of the US Deprescribing Research Network. We're super excited about today's webinar, which is about deprescribing interventions, learnings from an overview of systematic reviews. This webinar is sponsored by the US Deprescribing Research Network with funding from the National Institute on Aging. My name is Jennifer Chi, and I will be your host today. I am the co-lead of the Investigator Development Corps for the network. Before we get started, I need to cover a couple of technical details. Due to the number of registrants for today's webinar, we have placed the phone lines on mute to reduce audio feedback. So unless you're logged in as a host or panelist, your line is muted. However, we welcome and encourage audience participation using the Q&A feature on the Zoom webinar software. When you would like to interact with the presenter, click the Q&A bubble icon at the bottom of your toolbar and type your questions in the box. If you would like your question to be anonymous, you can check the anonymous box before sending. The host will acknowledge your questions during the final 15 to 20 minutes of the webinar. And after the webinar, please note that you're going to receive an email with a short evaluation survey. If you have any technical or logistical questions, we ask that you submit those using the chat box and select the co-host, Jonathan Norton, to chat privately. Please make sure you're identified either by name or by participant ID so that the webinar host will be able to help troubleshoot any problems you're having with the audio or any other issues. And before we begin, I'd also like to extend a huge thank you to Gabrielle Schiller from Mount Sinai, Jonathan Norton from Johns Hopkins, as well as Raha Shahroudi and Haley Schiff at UCSF, who do all of the amazing work behind the scenes to make these webinars possible. And now, without further ado, I'd like to introduce our webinar presenter, Dr. Shelly Gray. Dr. Shelly Gray is professor and endowed chair of the Plein Center for Geriatric Pharmacy and Research, Education and Outreach at the University of Washington School of Pharmacy. As the inaugural director of the Plein Center, she oversees the efforts to advance geriatric pharmacy education, research, and outreach to optimize older adults' medication outcomes and promote healthy aging. She has expertise in pharmacoepidemiology and has published several studies evaluating the risks associated with medication use. For example, anticholinergics and benzodiazepines, and their association with important health outcomes such as falls, fractures, and dementia. She is currently co-leading a deprescribing trial funded by the Centers of Disease Control and Prevention entitled Reducing CNS Active Medications to Prevent Falls and Injuries in Older Adults. She has been an investigator of numerous federally funded research grants and has authored over 130 peer-reviewed publications. Thank you, Dr. For coming to join us, and Dr. Gray, and I'm going to hand this over to you.
Great. Thank you, Dr. Chia, for that introduction. And I do want to thank you for the opportunity to present at the seminar today. Before I get started, I would like to acknowledge all of the collaborators that made this project possible. It really was an international effort, if you look at the co-authors that are on this project. And I also want to give a special thank you to our expert panel members, which represent leaders in the field of aging research in pharmacy, nursing, and medicine. This work is one of the work groups that was funded under the US Deprescribing Research Network. And so I, again, want to acknowledge that funding source, which is Mike Steinman and Cynthia Boyd are the multiple PIs. And I have no disclosures. So the objectives for this presentation is first, I will be giving an overview of the approach and rationale to conducting an overview of systematic reviews. I will discuss the study methods and results as it relates to vulnerable subgroups and downstream outcomes. Then I will also describe opportunities to enhance future deprescribing research.
I'm sorry to interrupt. We can see your presenter view. I don't know if that was what you intended or.
Oh. Thank you for that.
Yeah.
Thank you. Okay. So deprescribing has been described as a priority for older patients to address significant polypharmacy and quality of prescribing. And there are various definitions for deprescribing, but the one that we chose for this work is a process of discontinuing or reducing the dose of medications that are no longer needed or where risks outweigh benefits the medications are inconsistent with goals of care. And we know that there are several studies in this area that have evaluated deprescribing. However, rigorous evidence to guide deprescribing is limited, and future priorities for deprescribing research and practice remain somewhat unclear. And so the challenges that have contributed to the heterogeneity of the evidence in this field include lack of a consistent definition of deprescribing, challenges with outcome measurement, poor reporting of studies, and then also variation in study design. And we also know that the effectiveness of deprescribing interventions might differ according to patient characteristics. Thus, information according to these subgroups is needed. For example, older, frail individuals might be more susceptible to adverse drug reactions to medications, and therefore, deprescribing interventions might have more of a benefit in terms of the potential for reducing these ADRs in that subgroup. So the objective of this project was to examine whether deprescribing interventions lead to a difference in outcome amongst older adults. We also wanted to synthesize results according to the focus of the intervention. And there are two main types of interventions that we examined. One was deprescribing specific medication targets or therapeutic classes or therapeutic area, and then or general deprescribing, such as a comprehensive medication review. And then we also wanted to examine the effectiveness of deprescribing interventions according to patient subgroup characteristics. And these were advanced age, dementia status, frailty, and multimorbidity, and then also by intervention type and setting. And the key question that we were trying to answer with this work was, with limited healthcare resources, which deprescribing efforts will provide the most benefit? And so when we started this project back in September 2019, we did an initial scan of the literature, and we turned up roughly 13 systematic reviews on deprescribing interventions in older adults that had been published in the prior 3 years. And so when we met with our expert panel, we received advice that perhaps the real benefit of this work could be in summarizing the existing systematic reviews that exist in this space. And so we pivoted from doing a systematic review to answer the objectives that I described to a different study design, which was novel to me, which is an overview of systematic reviews. And so this methodology has gained widespread acceptance to compile evidence from multiple systematic reviews of interventions into one accessible and usable document. And you will also, when you review this literature, you will see many other terms used to describe an overview of systematic reviews. So you might hear terms such as umbrella reviews, meta reviews, reviews of reviews, or synthesis of systematic reviews. But the terminology that Cochrane has adopted is overview of systematic reviews. And overviews have evolved to address a growing need to filter the information overload, improve access to targeted information, and inform healthcare decision-making. So it's a very important tool to summarize existing research or highlight the absence of evidence. And so we found ourselves in the fall of 2019, pivoting, and instead of doing a systematic review to answer our research questions, we embarked on conducting an overview of systematic reviews, just because of the sheer number of systematic reviews that were available. And so it was a learning curve. Luckily on our team, we had individuals that had conducted overviews. So we did have that expertise on our team. And although there's guidance for conducting overviews, there are several areas that are still remain challenging and uncertainty about how to approach. And so the first issue is how to address overlap between reviews. So multiple primary studies may be included in different reviews. And so there's no consistent way to address this overlap that might occur. There are different approaches, but there's no gold standard. Another challenge is, the definition of a systematic review. And this is especially problematic for those systematic reviews that were conducted prior to PRISMA guidance. And so there is a method to determine for those types of reviews if it qualifies as a systematic review or not. And there also is a challenge in terms of assessing the quality of the systematic reviews. And one of the leading ways to assess quality of the systematic reviews is a tool called AmStar, which I will describe in more detail. There's also challenges regarding the quality of reporting within reviews. So in an overview, you are dependent on what the narrative synthesis and conclusions made by the systematic review. And the quality of reporting varies among systematic reviews. Another key challenge is, how do you take all of these systematic reviews and summarize the key findings in a brief, easy-to-use format? So my goal here was just to introduce some of the challenges that occur when when conducting an overview, and I'll touch on how we address them as later in the presentation. Okay, so now I'm going to describe the methods that we used for this overview. We first developed our protocol and registered this with Prospero. And then we used the PICO methodology to define our eligibility criteria for which systematic reviews would be included. Our population consisted of studies that were the mean age of individuals was 60 years and older. We had the interventions we were interested in were, as I mentioned, we looked at reviews that specified a specific target. So that could be a single medication, a medication class, or a therapeutic category. We also included what we term general deprescribing studies. This included interventions such as comprehensive medication review and goals to reduce polypharmacy or potentially inappropriate medications. We also included interventions of investigator-initiated medication withdrawal. We required reviews to have a comparison with usual care or with regard to the investigator-initiated studies, the control group or comparison group would be those who continued medication. And then the study designs that we included were randomized trials, non-randomized trials, controlled before and after studies, and so forth. The key is that all study designs had to have a comparator group. So in terms of outcomes, we had we grouped our medication-related outcomes into 2 different categories. So we had, the first was medication reduction, and this included number of medications, dose reduction, and then discontinuation. And then there were, our second category we grouped were just other medication-related outcomes. This included potentially inappropriate medications as defined usually by stop or the Beers criteria, medication appropriateness, and adherence. And then we looked at 9 additional outcomes. We looked at surrogate biomarkers. This was blood pressure control or glucose control, mortality, quality of life, healthcare use, so emergency department visits or hospitalization, patient treatment burden, falls, cognition, adverse drug events, and cost. And we did not find an outcome set specifically for deprescribing studies, but we adapted this from an outcome set that was designed for polypharmacy studies by Rankin et al. So here's the conceptual model. Again, our population were those individuals 60 and older. We looked at interventions that focused on a single medication target or just general deprescribing. And then we had our 2 medication-related outcomes. And then this, so that's the immediate effect of the intervention. And then these are what we term other outcomes, but they really include clinical outcomes, mortality, healthcare use, adverse events, and patient-centered outcomes. And then we were interested in these patient subgroups. So we were interested in, did interventions vary by age group, frailty status, dementia, multimorbidity, or setting. So we spent time with the research librarian to develop search strategies. We searched 11 different databases, and the time period we searched was between January 2005 and October 2020. Title, abstracts, and full text articles were screened by 3 reviewers, and consensus was used if there were discrepancies. We extracted data in duplicate. We assessed the quality of the systematic reviews using the multiple systematic reviews tool, or AMSTAR. And this is a 16-item tool that assesses various aspects of systematic reviews, such as comprehensiveness of the search strategy, if the PICOs were defined clearly. And so based on the ranking, based on these 16 criteria, systematic reviews are categorized as high, moderate, low, and critically low in quality. We also address the overlap in the reviews by presenting a matrix of the primary studies and reviews, and then calculating the corrected coverage area, or CCA index. This is one way to present the degree of overlap that is suggested. We had a CCA of 2.2%, which is consistent with mild overlap among the reviews. Okay, in terms of our methods, we describe and synthesize results in 2 steps. The first step was at the review level. So it's basically a summary of the reviews. And this included characteristics of the reviews, such as the outcomes that were identified, the population, the age, and those types of issues. So we have a table that describes the characteristics of reviews. We also have a table in the manuscript that summarizes the author's conclusions and also the effect size and confidence intervals for any results of meta-analyses that were included in the reviews. Our step 2 was a narrative synthesis. And so within each review, there was a subset of articles that might not have met our P codes. So they might not have, had a rigorous study design as we defined. And so those studies were not included in our narrative synthesis. And what we did is we summarized the results according to outcome from these eligible primary studies. And this information was basically taken from the narrative synthesis of the review. And then for the outcomes, we summarized the outcomes into 6 mutually exclusive categories to describe the broad findings of the review. And this is actually one of the tricky parts of doing an overview, as I mentioned, is how to present the information in a way that's clear and usable by various stakeholders. So after much consultation with our expert panel, we came up with this schema to define, to summarize the broad findings by outcome. So we had, so if you think of one review and one outcome, say the outcome is discontinuation, the studies in that review might have had, all studies might have reported a statistically significant benefit of the intervention on discontinuation. If that was the case, then we group that review as beneficial effect only. That same review could have a mixture of primary studies where there was a beneficial effect, and then also some studies that showed no evidence of effect. So the intervention did not reduce medication use. In that case, that review would be categorized as beneficial effect or no evidence of effect, because there were both of those findings were evident in their synthesis. So the third category was no evidence of effect. The next category was mixed. Basically, there was some primary studies that found a beneficial effect, some no evidence of effect, and then some actually finding a negative effect. So the intervention, may have increased medication use. And then the next category is no evidence of effect or negative effect, and then lastly, negative effect only. So for each outcome in each review, we summarize the information for that outcome into these 6 mutually exclusive categories. And I do want to point out here, because this was an issue that our group struggled with, because some of the studies reviews might not have been powered to examine an outcome, and these are mainly the downstream outcomes. No evidence of effect might just reflect that the study was underpowered to find a difference, rather than being that there was really no effect between the intervention and comparator group. Okay, so this is our Prisma flow diagram. We had roughly 4,000 articles that were identified. And after the full text review, 33 reviews were included, and 13 of these included a meta-analysis. Okay, so in terms of the results, I'm going to first start with step 1, or the summary of the reviews. So 13 reviews focused on specific medication targets, and I've listed the specific targets there for you to read. 19 reviews focused on general deprescribing. Again, this was reducing PIMS or polypharmacy. And 1 review included primary studies that focused on both types of targets, so both specific targets and then general deprescribing. In terms of the AMSTAR assessment of quality, 29 were rated as critically low and 4 reviews were rated as low. In terms of setting, you can see that that roughly half of the reviews included primary studies from multiple settings. And then you can also see that, inpatient, some reviews focused just on inpatient studies. About 12% focused on long-term care, and another 12% on outpatient settings. In terms of outcomes, you can see that, again, about a little bit more than half of the reviews included both medication-related outcomes and other outcomes, and then about a quarter of reviews reported on medication-related outcomes only. Since we were taking information about the review characteristics from the P codes, you can see that for some, there was no specification in the P codes or the methods of the study in terms of what outcomes that they were focusing on. So 9 reviews specified an objective of evaluating harms of deprescribing, and with only 5 of these reviews defining which outcomes they considered harm. Mainly, this would be adverse drug events or adverse drug withdrawal events. But sometimes by reading the review, you could glean that the authors thought other outcomes were harm, such as mortality, but it wasn't always stated what outcome was considered harm. 8 reviews specified adverse drug withdrawal events as an outcome of interest. Okay, so I'm going to present the results for those studies that conducted meta-analyses. And I'll first present the medication-related outcomes. So 10 of the 33 reviews included a meta-analysis of a medication-related outcome. And of these 10 reviews, there were 29 outcomes. So reviews had conducted a meta-analysis on more than one medication-related outcome. And you can see about 3/4 of these reviews, the intervention resulted in a beneficial effect on the medication-related outcome. In about 1/4 of them, there was no difference between intervention and control group. And then there was one review where the outcome was better in the comparison group. So actually, in this case, the medication increased more in the intervention group than the control group. This slide kind of breaks this down further. So again, these are the 10 reviews that included a meta-analysis for a medication-related outcome. The second column gives you an idea of what the medication-related outcomes were that were included in the meta-analysis. And then the third column demonstrates either the number of outcomes that were analyzed using in the meta-analysis or the number of comparisons. And so to give you an example, like the meta-analysis that was conducted by PAR, in that review, they had 7 comparisons by intervention type compared to control. So anyway, you can see there was a wide range of the medication-related outcomes from individual medications such as hypnotics, benzodiazepines. Some focused on potentially inappropriate medications or the medication appropriateness index. So there was a wide range of medication-related outcomes that were included, that were meta-analyzed, I should say. And I want to draw your attention to this column. So these are the 21 comparisons where the intervention was statistically significantly improved the medication outcome. And then here are the 7 studies where there was no evidence of an effect. So you can see, like for individual review, like for PAR, there were 4 comparisons where it was statistically significant improvement with the intervention, but in 2 comparisons, there was no evidence of an effect. This slide demonstrates the results from the reviews that had meta-analyzed one of the other outcomes. So these are the other outcomes. Again, this is the number of reviews. And so for mortality, 5 reviews had provided a meta-analysis of the intervention effects on mortality. And you can see that in 1 review, that there was a statistically significant reduction in mortality with deprescribing interventions. For 3 reviews, there was no evidence of an effect on mortality. And then 1 review, there was mixed effects according to study design that were meta-analyzed. So in this study, when the meta-analysis included non-randomized studies, there was a significant reduction in mortality. But when a second meta-analysis was done with just randomized studies, there was no significant reduction in mortality. By far, most of the results of meta-analyses of these other outcomes fall into this area of no evidence of an effect. So now I'd like to present the results from our narrative synthesis by outcome. Focus on the medication-related outcomes first. So again, we had our 2 different categories of28 outcomes. The first outcome was focused on medication reduction or discontinuation, and there were 28 outcomes available from the narrative synthesis. And here are our 6 mutually exclusive categories that describe the broad findings across the review. And I wanted to focus on these 2 columns, where the first column is beneficial effect only. So that would be a review that scored in this area would be every single primary study in that review found a beneficial effect of the intervention on medication reduction. The second column, beneficial or no effect, means that there were some studies that found a beneficial effect, but some also found no effect. If we consider that these 2 categories, or these two categories kind of represent the best case scenario of, benefit effect on medication reduction, you can see that most of the studies are falling in these 2 categories. So 25 out of the 28 had a beneficial effect only, or beneficial effect or no effect. If we look at other medication-related outcomes, again, that includes PIMS or medication appropriateness. We see, 11 of the 13 reviews fell into these 2 categories, with 6 finding a beneficial effect only and 5 finding either beneficial effect or no effect. There was one study that actually found an increase in medication use in the intervention group. So that would be classified as a negative effect only. Okay, so this slide shows the basically the results of the narrative synthesis on our other outcomes. Again, we had the same mutually exclusive categories. You can see that the most common other outcomes that we extracted data from reviews on was mortality, quality of life, and adverse drug events. So there are 15 outcomes each for these other outcomes. The slide, I'm still pondering what this slide means, but I just want to point out a few highlights. When we look at adverse drug events, there were 6 reviews where there was a beneficial effect, meaning that there was a reduction in adverse drug events. And then there were 6 where there was no effect. And there was, what I think is a positive finding is that there was only 1 review that reported an increase in adverse drug events with the intervention group. You can see that most of the findings for these other outcomes are either beneficial or no effect, or no effect. And falls, I thought was another interesting point, that with falls, of the 8 outcomes, that 5 reviews found a beneficial effect or no effect. And so I think this is one of the outcomes where, you're seeing some, potentially some benefit here. And then I also want to point out that for the outcome of cost, we found very few reviews that focused on cost. Okay, so results of the subgroups. Again, we had our 5 pre-specified subgroups, and the data for the subgroups came from either the meta-analyses or from the narrative synthesis. So for age, so to orient you to this slide, this is the subgroup. The number refers to the number of reviews where information was available about the subgroup. And then I presented it separately according to if the information came from the results of a meta-analysis or if we found the results within our narrative synthesis on the subgroup. So for age, there was 1 review that provided information. So the effect of interventions on mortality did not seem to vary according to age subgroup. If we look at dementia, there were 3 studies that provided information about this subgroup. And there's only 1 systematic review that actually provided information according to dementia status. So I'm going to focus on that. But basically, deprescribing interventions on effect on mortality did not seem to vary according to dementia status. There are a little bit, differences in the odd ratio, but these were not statistically significant. If we look at the outcome of interventions on psychotropic use, there was 1 review that provided a meta-analysis, and this was only in people who had impaired cognition. So we don't have the comparator group of people who had intact cognition, but this does provide evidence that deprescribing interventions were effective in reducing psychotropic use in people with impaired cognition. This is similar. Also, we found in our narrative synthesis that there was 1 review that did comment that interventions did reduce inappropriate antipsychotic use in people with dementia. Again, we don't have the comparator group, but it does show that there is evidence that the intervention is effective, I guess, on medication use in people with dementia. Frailty, we did not find a review that did a meta-analysis according to frailty status, but actually Dr. Chia's work is reflected in this in terms of our narrative synthesis, where they define frailty based on hospice and various characteristics that define a frail group of people. And they found that interventions did reduce unnecessary medication use in this frail group of individuals. In terms of setting, we had 12 reviews that provided information about how interventions might vary by setting. One review did a meta-analysis according to setting. And in this, it was found that interventions did reduce medication use in the outpatient setting, but not in the hospital setting. And then we did find, we felt another way to look at if interventions were effective in various settings was to focus on those reviews that looked specifically at a single setting. So it's not compared, again, comparing different settings to each other, but is providing some evidence of like what happens when interventions are done in just, long-term care, for example. And we did find evidence of benefit in our narrative synthesis for a long-term care that 1 of 4 reviews found clear benefit, and that goes to that first category in our the prior tables that I've showed you. So clear benefit is like benefit only. For hospital setting, all 3 of 3 reviews found clear evidence of benefit. And in the outpatient setting, 2 of 4 reviews found clear evidence of benefit. So again, I think the one thing to take away from this is it's a little bit difficult because reviews are reporting on different outcomes. But the general conclusion I have come to from looking at this and sitting with this for some period of time is that there is evidence, especially for the medication-related outcomes for some of these subgroups, but the other outcomes, such as mortality, again, we might not just have the events in power to really look at those in a robust way. Okay, the last subgroup I'd like to discuss is intervention type. And we had 6 reviews that addressed how interventions might vary according to the intervention type itself. And so you can see we have a various different outcomes that were examined. We have medication-related outcomes and then mortality and hospitalization. And you can see that another thing I want to point out is the reviews varied considerably in terms of how interventions were categorized. So this makes it a little bit challenging in terms of trying to draw conclusions. But you can see that the several interventions were effective for reducing number of medications. So patient-centered and healthcare professional-centered interventions were effective. For medication appropriateness, medication review and computerized decision support were effective in improving medication appropriateness, but multidisciplinary meetings and staff education were not. Various interventions have been effective for reducing benzo use, but therapeutic substitution has not been found effective. For mortality, patient-specific interventions were effective in reducing mortality, but educational programs were not. So this was from the same study. And then another study found that intervention, using doing CMRs reduced mortality. So this gives you a general overview of how interventions might vary in terms of effectiveness on these different outcomes. So, okay, I'm going to summarize briefly so we have time for questions. This was the first overview of systematic reviews of deprescribing in older adults. In terms of our narrative synthesis according to outcome, overall, we found that interventions generally resulted in medication reduction if you consider both those two first columns or categories of effect, but resulted in mixed effects or no evidence of an effect for other outcomes. ADEs were reported in nearly half of the reviews, and it was promising that only one review found an increase in ADRs with deprescribing interventions. The results from the meta-analyses, we see the same pattern, similar pattern of results as we do from the narrative synthesis. And then few reviews focus on how intervention effects varied according to the patient characteristics or setting. So as I alluded to earlier, many primary studies are not designed or powered to examine those downstream outcomes, which we labeled as other. And because of this, many times there are secondary outcomes in these studies, understandably. So it's really important to remember this when we're trying to interpret what no evidence of effect means in this context. It's not stating that, oh, look at interventions, deprescribing interventions don't seem to cause harm because they don't cause increase in mortality or in those other outcomes. Most likely it's due because we don't have power to look at those comparisons. Generally, the AMSTAR2 criteria are very robust criteria, the reviews that were included were of low quality based on those criteria. Examining harm of deprescribing was not often specified as an objective. And then in going back to the main goal of this overview, it was difficult to determine, how to prioritize medications or patient groups that would benefit most from deprescribing based on this work. However, we did identify, I think, several gaps in the literature that will hopefully translate into future research endeavors. I think defining and examining potential harms of deprescribing is very important. Developing a standardized set of clinical measures, which especially include like all of these outcomes, but especially patient-centered outcomes. I think this is an area where we have some hope, I think, in terms of designing studies that are powered to find differences in patient-centered outcomes, where we might not be able to, even in the largest study that, we could feasibly design, we might not be able to ever determine if there's an effect on mortality or not. Strengths, this is comprehensive. We addressed a unique gap in the literature, and we adapted a core outcome set for polypharmacy to conceptualize our results. There were several limitations. I'll just touch on the biggest. Due to what the goal of an overview, we aren't going to be capturing large, recently published deprescribing trials. And we do know, like in 2022 alone, there were 3 important studies that were published, by Drs. Bayless, the 3 studies, McCarthy and McDonald. There's some excellent studies that were published, but aren't reflected in this work. And the important thing about those 3 studies I just mentioned is that they do focus on vulnerable subgroups in people who have dementia or multimorbidity, which is one of the gaps that we identified. Extracted data is dependent on the reporting by the author of the reviews, and it often varied in quality and style. And I think an important limitation and need for further research is we weren't able to determine the association between the success of medication-related outcomes, the intervention on the medication-related outcomes, and what impact that has on the downstream outcomes. If we're only seeing small effects on the medication-related outcomes, it may be of no surprise that we're not seeing robust effects on the downstream outcomes. So in conclusion, interventions generally resulted in medication reduction. Information about other outcomes were not routinely examined. The evidence, though of low quality, suggests deprescribing was not associated with increased risk of adverse events and had little evidence of effect on these other outcomes. But nonetheless, we know that polypharmacy and use of high-risk medications can cause great concern in older adults. So regardless of the findings, clinicians should continue to look for opportunities to deprescribe inappropriate medications using shared decision-making. And thank you so much for your attention.
Thank you so much, Dr. Gray, for that monumental lift at reviewing the literature and the literature on systematic reviews. We do have a few questions, and some that touch on some of the limitations. There's one question about actually your thoughts about how the studies that were included addressed duration of follow-up to the interventions, and how maybe the design or lack of follow-up contributed to the measurement of medication-related outcomes like falls and mortality, and what should we do about that?
Yeah, so that's a very important question because of the because of the variation of duration of these studies within each review. That was something that was not extracted, but certainly, you know, the duration did vary considerably. You know, we had studies that were done in inpatient. You know, that follow-up time is going to be short compared to, you know, some studies that, you know, had a year of follow-up. And so certainly the longer the follow-up, the more likely you are able to look at some of those other outcomes, such as falls, you know, mortality and such forth. So duration is very important and was not something that we captured in this overview.
Understandable that the outcomes are so heterogeneous. Also related, so adverse drug events, how was that defined, and how did you know, or was it reported in the studies about whether the adverse drug events were really related to the intervention or not? Could you take that out and tell that, and make a conclusion about that?
Yes, I will do my best. So one of the challenges was adverse drug events in the review wasn't always defined, like what is an adverse drug event. So some reviews did not separate adverse adverse drug reactions from adverse drug withdrawal events. You know, so that was so one limitation is sometimes adverse drug events did include adverse drug withdrawal events, and it wasn't reported separately. That was especially a concern with some of the earlier publications. I think now current research is focusing on, making sure we separate out adverse drug withdrawal events from ADRs, because, the big problem, as you would expect, is that with them rolled up into one outcome, with deprescribing interventions, you would expect an increase in AW adverse drug withdrawal events and a decrease in adverse drug reactions. So you have two different directions of those sub-outcomes within the larger outcome of adverse drug events. So I think that's a very important area for better definition and more standard data collection around those two outcomes that are rolled up into adverse drug events.
Right. So it sounds like you'd wish that it would have been reported differently, and then you could have rolled it up differently. Related to that, this is a lot of kudos, and thank you, Dr. Gray, for this work. According to the AmStar method of evaluating the quality, the studies included were critically low or low. Did you notice a trend for the reasons for the low ratings that would suggest better quality studies might find different results?
Yes. So the AmStar, this area again is, assessing the quality of the systematic reviews is a challenge. And so the AmStar 2 were recently updated. And these are the three criteria that, like these are the critical domains. So if you score low in just one of these, you're automatically a low quality study. And so two or more, you're critically low. It's a critically low study. So yeah, these were the ones that the reviews they scored poorly. So evaluation of the search strategy, justification of exclusion of studies. So, some reviews did not have a table that explained, what criteria was responsible for a study to be excluded from the review. And then evaluation of publication bias. So these were the three most common critical domains that the reviews scored poorly on. And there's no other overviews have modified the AmStar criteria. And there's some hint within the criteria that these can be used, maybe you don't have to apply them strictly to your reviews, but in the absence of not having better guidance about how to use, the AmStar, we followed it, exactly how it's instructed to use. So I think the tool might be a little harsh on these reviews. There were some very good reviews, in my opinion, and many of them are probably some of the authors are on this call. So anyway.
Yeah, no, it's a tough business, and no, thank you for that response. We have 1 minute left and more questions than we can do in the next minute. So I wanted to leave the last word with you. I think that we all on this call are committed to deprescribing, and I know clinically people are really worried about the harms of deprescribing. And what message do you think we can take away from this review that might be either reassuring to clinicians or not? Or what big ask do you have of our research community to help move this work forward?
I think the one issue that really stood out to me was I really feel like we need more evidence in our more vulnerable patient groups, and and some of that is being addressed, as I mentioned, in some of the newer studies that have been published. I really do think it's important to study harm and explicitly state and define harm. But with that said, even these large studies that were just published, they recruited, a large number of patients. And it was kind of humbling to me that even recruiting thousands of patients, because adverse drug withdrawal events serious adverse drug withdrawal events are relatively uncommon. We're not really, going to be powered, I think, to see differences in that outcome. And that might be okay. So even though I say we need more information on harms, those would really need to be pretty large studies in order to determine that. So maybe the best that we can do is just describe, you know, the serious harm from these medications in a more descriptive way. But in general, I think, yeah, just being more clear about how we define harm, and then also measuring average drug withdrawal events separately. I think that's like a probably a very actionable item from this work.
Terrific. Thank you so much for presenting, and thank you so much for doing this heavy lift. And I wanted to thank all of you who have attended the webinar and for staying the extra few minutes. A recording of this webinar is going to be posted at the US Deprescribing Research Network website, and we will send you all a brief evaluation right after this webinar is over. Please fill that out so we can get your views. Thank you, Dr. Gray. Thank you, team. Thank you, attendees, and have a great rest of your day.
Thank you so much.